a country excelling in every field, from sports to scientific achievement, and inspiring others to follow their path. Epidemiology of clubfoot. The global incidence is approximately 1.2 per 1,000 live birth. More common in male.
Sorry sir, sorry Khan sir, sir आपको slide change भी चाहिए ना? आपका slide change नहीं हो रहा है. आप प्लीज जब भी आपको स्लाइड चेंज चाहिए एक बार बोल दीजिएगा, आप देर से स्लाइड चेंज कर देंगे.
Okay. Go ahead, please.
Abdesh sir, please go ahead. Slide change.
No. Back, please. Back.
Please. Abdesh sir.
Okay.
Yes.
After
That side, or shall I?
After that, epidemiology.
Okay. Just a second. This one.
Yes.
Yes.
Yes. Continue.
Global incidence is approximately 1.2 per 1,000 live birth. More common in male is 2:1 ratio. In India, approximately are born with the clubfoot each year. Only 50% properly. It means we are treating only about 5,000 children. Clubfoot is one of the most common orthopedic disability in developing nation, like our country. Go ahead, please. Next. Classification of clubfoot. Not all clubfoot cases are the same. A standardized classification ensure effective communication and treatment. Most of the clubfoot are idiopathic. It means there is no cause. Secondary clubfoot is associated, though there is a clubfoot, but along with the clubfoot, it is also associated with some neurological or syndromic disorder. One more type clubfoot is mostly by fault. People recognize that this is also in a category, but this is not real. That is called the positional clubfoot. Actually, this clubfoot later on it's correct automatically. Next, please. Next.
Slide, please. Abdesh sir, next slide, please.
If we are talking about the most common type of the clubfoot, that is the idiopathic, means baby has a clubfoot, otherwise baby is normal. Means सिर्फ उसको जो है पैर उसके टेढ़े हैं और कोई उसको दूसरी बीमारी नहीं है, दूसरी डिफॉर्मिटी नहीं है. Itself there are different type of the categorized. Untreated clubfoot means newborn up to 2 years old with little or no treatment. मतलब कि 2 साल तक बच्चा हो गया है, उसको थोड़ा या ट्रीटमेंट उसको मिला ही नहीं. That is called या are put in the untreated clubfoot category. Treated clubfoot means successfully corrected through Ponseti technique and bracing. Here I emphasis over the Ponseti technique. Next is the recurrent clubfoot, means deformity recur, often due to premature discontinuation of bracing. Neglected clubfoot, a clubfoot in children who are 2 years old with little or no treatment. मतलब कि बच्चा 2 साल का हो गया और उसको कोई ट्रीटमेंट मिला ही नहीं. Complex clubfoot, deformity complicated by previous non-Ponseti treatment. यानी कि complex clubfoot मतलब कि उसको हम लोग अपने अपने तरीके से ट्रीटमेंट दे रहे हैं, but they are not strictly follow the Ponseti technique. Either they don't know or what are the reason, I don't know. Resistant clubfoot, correct Ponseti treatment fail to show significant improvement, often due to underlying syndrome. Means उसको हमने कॉन्सर्वेटिव टेक्निक से उसका हमने ट्रीटमेंट किया, लेकिन उसके बाद जो है कुछ उसमें न्यूरोलॉजिकल और सिंड्रोमिक कंडीशन थी जिसकी वजह से वो रिकर कर गया। हमने इलाज तो उसको कॉन्सर्वेटिव टेक्निक से ही किया। That is categorized under the resistant clubfoot. Atypical clubfoot, uncommon cases with the additional complications such as the swollen foot and extended big toe. Next, please. Assessing clubfoot severity. How the person or the medical personnel or person from the RBSK who is working in the field, how they identify what are the severity of the clubfoot. For that, we have to learn about the severity. For that, Dr. Shafiq Pirani, who is a Canadian orthopedic surgeon, developed a Pirani scoring system to objectively assess the severity of clubfoot and monitor ट्रीटमेंट प्रोग्रेस। मतलब कि इसको हम जब ट्रीटमेंट शुरू करते हैं उसके बाद जब आता है तभी हम देखते हैं कि जो हम ट्रीटमेंट दे रहे हैं कॉन्सर्वेटिव टेक्निक से इसकी प्रोग्रेस कैसी है। नेक्स्ट प्लीज। अंडरस्टैंडिंग क्लबफुट डिफॉर्मिटी, हमें समझना पड़ेगा कि ये क्लबफुट डिफॉर्मिटी कैसी होती है। इसकी एक निमोनिक है केव, CAVE, इसी से इसकी जो डिफॉर्मिटी है वो डिस्क्राइब की जाती है। C इज द केवस। केवस सिंपल भाषा में अगर इसको समझें तो इसका फुट का आर्च जो है वो नॉर्मल आर्च से ज्यादा होता है। हाई आर्च ड्यू टू द प्लांटर फ्लेक्शन ऑफ द फर्स्ट मेटाटार्सल। Second abnormality is adductus, medial displacement of the navicular bone, which is in the midfoot. Third deformity is the varus. Our heel shift inward or toward the midline. Equinus, excessive plantar flexion of the foot. मतलब जैसे घोड़े के उस पर जो है वो चलते हैं, इस तरह बच्चे का पंजा जो है बिल्कुल आगे को झुका हुआ रहता है। That is excessive plantar flexion of the foot. That is called equinus. Next slide, please. Concerti method. What is Concerti method? Concerti method. There is different type of the method which use. कोई सर्जरी इसमें नहीं करते हैं बहुत बड़ी. That has extensively researched and has shown 95% excellent result in clubfoot. It consists of two phases. Number one, manipulation and casting phase, which is weekly manipulation and casting for 4 to 6 weeks. Final deformity is equinus, as I earlier told, which is required simple percutaneous tenotomy. In most of the cases, about more than 90% cases required tenotomy, and that is the final. At that time, we apply the final cast. After that, once the manipulation and casting phase is completed, means कि बच्चे का अब इस स्टेज में पैर जो डिफॉर्म था वो सीधा हो गया, पैर हमने टेनोटमी किया, पैर जो है उसका नॉर्मल पोजीशन में आ गया है। अब इसको अगर हम यहीं पर छोड़ देंगे तो फिर रिकर कर जाएगा। इसलिए हमें इक्वली इम्पोर्टेंट है हमारे लिए मेंटेनेंस फेज। मेंटेनेंस फेज के लिए वी यूज द ब्रेस एंड दैट इज फॉर 4 to 5 years to prevent recurrence. Next, please. What challenges with the casting? बच्चे को प्लास्टर लगा दिया है तो क्या challenges face करना पड़ता है? Cast was not applied properly and it is slipped. तो क्या करेंगे उसमें? Go back to the doctor and do not remove cast at home. It's very important. Cast never remove at home. Immediately go to the doctor or clubfoot clinic. Cast has become wet, गीला हो जाता है due to the child peeing. Into that diaper are used correctly and the cast is not wet. Child has skin irritation due to the cast because we are using the plaster of Paris. It sometimes causes the irritation of the skin. In that case, skin become red or irritation. Immediately visit for the doctor. Child is crying continuously after the casting. It means there is some time impinge of the cast, plaster of Paris, for the skin. In that conditions, the baby or parents is go to the clubfoot clinic. Next, please. This is very important and need to learn each and every orthopedic surgeon. Most of the time when I am going to for the training, though they are good doctor, big orthopedic surgeon doing big surgeries, but this is the very simple but need skill in the doing a tenotomy. But that is called percutaneous Achilles tenotomy, and this need 90% of cases require tenotomy. Performed for this, we are using 15 number surgical blade. After that, we will get 10 to 20 degree of additional dorsiflexion of foot. After that, final cast is applied for 3 weeks. Next week. Challenges with tenotomy. अब उसके होगा, तो उसके लिए हमें उनको उनकी काउंसलिंग करनी है, उनको ट्रस्ट डेवलप करना पड़ता है. Parents sometimes refuse tenotomy because they are afraid. So, dear friends, tenotomy is a simple, painless procedure done under local anesthesia. Parent think is a big surgery. Tenotomy is an outpatient procedure, and the child can go home after a few hours on the same day. Child is crying a lot. Discomfort is of course there, but try to soothing the child. Parents try to remove the cast after a week. Cast tenotomy has to stay for 3 weeks. As earlier I told you, after tenotomy के बाद cast 3 weeks का रहता है. इससे पहले जो हम मैनिपुलेशन और कास्टिंग करते हैं वो वीकली करते हैं. But once we have corrected the equinus deformity after tenotomy, the last cast will be for 3 weeks. Next, please. What is the foot abduction brace? Very important, equally important as casting and manipulation. Tenotomy, equally important foot abduction brace. अगर आप इसको नेग्लेक्ट कर देंगे या ये सोचेंगे कि ये बहुत छोटी सी चीज है, तो फिर आपका सब कुछ बेकार हो जाएगा. इसलिए बहुत ध्यान देना है, रेगुलर इसको चेकअप करना रहता है. फुट एब्डक्शन ब्रेस एक बार 3 हफ्ते के बाद, फाइनल कास्ट के बाद जब बच्चा आएगा तब उसको हम ब्रेस पहनाना शुरू कर देंगे. ब्रेस इसका शूज होता है, आप जैसा देख रहे हैं फिगर में. पहले शुरू के 3 महीने में, फर्स्ट 3 months, baby has to wear brace for 23 hours. After that, 3 महीने तक 23 से 24 घंटे उसको पहना कर रखना है, 3 महीने तक. उसके बाद फिर उसको सिर्फ नाइट में नैप टाइम पहनाएंगे टिल बच्चे की उम्र 4 से 5 साल तक नहीं हो जाती है. वेरी क्लियरली फिर से मैं रिपीट कर रहा हूँ, वेरी इंपॉर्टेंट पार्ट इज, शुरू में बच्चे को 3 महीने तक ब्रेस पहनाते हैं, 24 घंटे पहना कर रखते हैं. उसके बाद 3 महीने के बाद उसको सिर्फ रात में पहनाएंगे अगले 4-5 साल तक. What strategies can help improve adherence with the bracing? एक अलग सा पहनता है बच्चा, एक अलग सा लगता है, थोड़ा सा डिस्कम्फर्ट महसूस करता है. Parent advisors, ensuring patient comfort in the brace, clear communication with the parents, regular review and follow up. Next, please. Next, please. What are the features of an effective foot abduction brace? Currently, at that time when I was a student, I was not having this type of the brace, but this brace is excellent, very good. Everything is inbuilt in the brace. Currently, we are using new type of foot abduction brace in which shoe can be adjusted to bar at 70-degree abduction as per required. What is this 70 degree? Once after manipulation and casting antinotomy done, foot at that time, उस टाइम आपका पैर डॉर्सिफ्लेक्शन में रहेगा और 70 डिग्री एब्डक्शन में जाएगा. At that is the time when you use the brace. Inbuilt dorsiflexion, there is 3 category. If your foot is at 90 degree, it means it's plantigate. और जब हम टेनोटमी करते हैं तो फिर ये 15 डिग्री और ऊपर चला जाता है. And that is the good sign for your treatment success. और हमको इसी पर रखना है, यानी कि 70 डिग्री एब्डक्शन और 10 to 15 डिग्री डॉर्सिफ्लेक्शन में रखना है. इस ब्रेस में इस तरह की सिस्टम ऐसा बना रहता है कि उसको आप उस शूज को 70 डिग्री पर फिक्स कर सकते हैं. हील कब रहता है इसमें? हील एज फार अपार्ट एज शोल्डर. अब ये सवाल ये उठता है कि हर बच्चा का साइज कैसे आप डिसाइड करोगे? तो इसमें उसको जो शोल्डर की जो चौड़ाई होती है, द ब्रेड्थ ऑफ द शोल्डर इज द साइज ऑफ द ब्रेस. नेक्स्ट प्लीज. नेक्स्ट प्लीज. Now challenges with the bracing. Brace is not worn correctly. Connect with the clinic staff to learn how to put on the brace. Brace is not worn for adequate amount of time. जैसा कि हमने बताया कि शुरू के 3 महीने हमें ब्रेस को 24 घंटे पहना कर रखना है. उसके लिए follow the instruction for wearing brace as demonstrated by the clinic staff. Since the foot look corrected, उसके पेरेंट्स को लगा कि पाँव तो ठीक हो गया है, इसको पहनाने की क्या जरूरत है? नो. ध्यान देना है कि उसको ब्रेस 4 से 5 साल तक जब उसकी एज हो जाएगी तभी हम उसको ब्रेस हटाएंगे. बट एट दैट टाइम आफ्टर 3 months ब्रेस wear only in the night time. Parents relocate and discontinue treatment. बच्चा अगर कहीं चला गया फिर तो हमें पता करना होगा या हमारे आरबीएसके की टीम क्या कौन-सी टेक्निक से उसका ट्रीटमेंट हो रहा है फुट का कि नहीं हो रहा है. ओनली शूज आर वर्न विदाउट द बार. कभी-कभी उनके पेरेंट्स कहते हैं कि सर इसको वो बीच का बार ना दे, खाली जूता पहना दे. नो, इट्स करेक्ट. इट्स नॉट गुड. Bar is mandatory along with the shoes. Otherwise, it will recur. Next, please. Consequences of untreated clubfoot. क्या होगा अगर बच्चे को ट्रीटमेंट नहीं दिया गया? It left untreated. Clubfoot lead to severe lifelong consequences. Land up for the disability. Come to you for the Divyang certificate, permanent physical disability, social stigma, which is very hazardous for the baby and its parents, and discriminations, limited education and employment opportunities, increased burden on families and its societies, negative economic impact, including loss of GDP of country. Next, please. How you recognize that this baby foot is going to be relapse? There are several signs. Is in Pirani score. Later, if any audience want to know how to score, how to know the Pirani score, later I will share my other slides. Increase in Pirani score, return to cave sign, C, cavus, adductus, varus and equinus. इसमें से कोई भी एक साइन अगर रिटर्न हो रही है, वापस आ रही है, तो समझो कि वो रिलैक्स हो रहा है. There may be a callus formation on the lateral aspect of the foot. एक उस क्योंकि बच्चा नॉर्मल फुट से तो नहीं चलेगा ना, लेटरल एस्पेक्ट ऑफ द फुट से चलेगा, तो वहां पर धीरे धीरे कैलस बन जाता है. इट्स वेरी पेनफुल. डायनेमिक सुपनेशन व्हाइल वॉकिंग, जब बच्चा चलेगा तो पैर उसका जो है, चूंकि लेटरल एस्पेक्ट से चल रहा है तो सुपनेशन में रहेगा उसका पैर. इफ रिलैप्स अकर, नॉट टू, please listen carefully. If relapse occur, not to hesitate, repeat casting and retinotomy as well. We can do. Next, please. Next, please. Clubfoot is a treatable conditions, and no child should grow up disabled due to lack of awareness or access to treatment. Very important. Again, I would like to repeat, no child should grow up disabled due to lack of awareness or access to treatment. With early interventions, proper medical training, and a commitment to the Ponseti method and Pirani scoring system, we can ensure that every child with a clubfoot in India has the opportunity to live a normal, fulfilled life. Next, I think. Next, please. Okay, thank you.
So thank you, Dr. Khan. This was great. And, we still have about 1.8 thousand participants. So our RBSK teams actually are contributing to some of the aspects of these three
Yes,
effects. So, and where DIEC are here, we have more facilities, but their private sector is participating. So we have a lot of treatment facilities coming up under the program. And therefore, we must continue to contribute without losing heart.
Sure.
Right? So we heard from three experts that primary prevention is possible for only some birth defects. Early detection is important for many of them, and we should contribute in various ways in finding them early and then getting them proper treatment. But treatment can be long, so therefore a good follow-up care must also be planned, and therefore lot of awareness and counseling to the families would be required. So all of us, we can contribute in several ways in this big issue of birth defects. And I agree with Dr. Khan that no child should be left to live with a birth defect, especially if it is treatable. So therefore, we commend that Government of India is putting so much effort, and there are philanthropists, there are NGOs who are contributing alongside. So all of us must continue to help the population. So once again, awareness, removing stigma, critically important. Some messages on prevention, help in early detection, help in proper and appropriate referral, get them treatment, but also encourage them for long-term follow-up so that we have the complete results. So that's the kind of something we heard from all three experts. And Dr. Khan also wants to add something. Dr. Khan.
One more thing, sir, I would like to add up.
Yes, please.
Sir, this program needs more training
Okay.
for the doctors as well as paramedical staff.
Okay.
So we can cover the root level, no
Right.
baby left without treatment.
Great. So that ideal situation will take little time. We are a big population. Resources are always limited. So we have to come together, and actually you are right. We should all work towards that ideal that everyone actually in the health sector able to help such families. Not only government, but private sector. Private sector sometimes does well. But there also, there is more than economic cost, there is social cost to it. So therefore, many times there is a failure even if they are able to afford treatment, still complete treatment is not done. So there are a lot of, aspects of this issue, and we have done much better than other countries, and we
Now-
should accelerate.
RVSK along with some NGOs, they are doing very well. And
Yes.
especially where I am doing running this clinic, especially at the
Yeah.
Barabanki, this NGOs, Anushka Foundation, they are having tie up with the RVSK.
Yes. So similarly for clefts, there is another NGO for congenital heart disease, another NGO. But in addition, while people are, asking for slides, Deepti and Shobna, would it be possible to give them the PowerPoint slides and the recording?
Sir,
Link?
we'll be sharing the recording of the webinar with all of them.
Very good.
Within a day or two,
Recording
we'll be
link will
sharing
be
it.
available. That would enable you and your colleagues who have not been able to join today, kindly
Yes.
pass on this information. And
Sir,
also
I would like to add in that everyone has joined from the IACO platform. So both PPT and the recording will be uploaded on the same platform. In the content tab, they can download or they can watch directly over the platform. All the participants have the access.
But can they also offer it to their colleagues who have not been able to attend?
You
and
can
also
they
see?
can download the same file.
Okay.
Rajesh sir, we'll be sharing it with the state nodal officers. Official
Also-
mail will be sent and they'll be further disseminated into the ground level from the state itself.
Okay. So there are some questions in the chat box. If
Yes, sir.
Deepti, there is time, shall we take few?
Sir, I think, sir, because people have written questions, we can just take them quickly and briefly request our experts to answer them, touch upon those points. One question that has been come repeatedly is how to differentiate between the murmur in CHD and anemia.
Hmm.
Adi sir,
And a functional
saying-
murmur. Somebody said, there is a murmur, but echo is normal.
yes.
So Adi,
Yeah,
what to do?
so functional murmur, if your other cardiac evaluation is fine, then you supposedly label it as a functional murmur. And functional murmur is mostly due to an overflow situation, such as anemia, such as thyrotoxicosis.
Hmm.
So these are murmurs which is a flow murmur because excess blood flow with a high velocity is flowing across a wall. So that gives the sound. If your X-ray is normal, clinical examination is normal, we label it as a functional murmur. And
Okay.
functional murmur is usually heard in pulmonary area.
Okay.
So we have auscultatory areas on chest. If the murmur is on the left side of your chest and upper area, and clinical examination is normal, your saturation is normal, and child is growing well, everything is well, then you label it as a functional murmur.
So in some cases there may not be any need to do an echo also, if all these
Yeah,
criteria are good.
Yeah.
Okay, if you are clinically sure, you can make a little bit of certain decision. But whenever in doubt, you get to echo done. If echo is normal, chest X-ray is normal, then we have to ignore. If the stethoscope was showing a murmur, then you can rule out heart disease. Then that is very reassuring for parents also. Deepti, more questions?
Murmur के ऊपर anemia, physiological murmur.
Hmm.
That sir is already
Maybe
taken.
Answered.
Yeah, these
Yes.
are all same. physiological
Yes.
murmurs or
Adi,
functional
sir?
murmurs. Yes.
Adi sir, will you be able to talk in brief about the antibiotic prophylaxis that is needed for dental work and importance of dental thing for our CHD patients?
Yeah, dental hygiene, I'll just like to stress upon because this is a very important thing. Most of the children which we see, all of them have some dental problems already. So it has to be emphasized if the child has congenital heart disease, then dental hygiene has to be lifelong, even before surgery and after surgery. Before surgery, it has implications that they have a risk of infective endocarditis due to poor oral hygiene and dental caries. And routine dental hygiene is expected out of the children twice a day brushing teeth. And if a smaller child where brushing is not possible, then every time the parent should clean their mouth. After eating chocolates, they should just gargle it out. They should just wipe off with some, just like gargles we are doing, with the normal water. Nothing should be in the mouth after eating. That habit should be developed in children. And in elderly child who is able to brush his teeth, twice a day brushing should be there. And it should be gentle brushing, not very, means you should not be very harsh. It should not bleed out your gums and all because that also promotes bacteremia. So daily this thing twice a day brushing is advised for such children. Coming on to antibiotic prophylaxis, then certain high risk conditions are there with high risk conditions with high risk lesions. Those are the conditions where prophylaxis is needed. If at all, I'll have to see that high risk conditions are if a child already has one episode of infective endocarditis. Then for any procedure, small procedure, we will advise him to take antibiotic before any procedure. If the child has a prosthetic valve, suppose the bioprosthetic valve has already been put, then antibiotic prophylaxis will be advised. If a child has a prosthetic material, suppose the mitral valve was repaired, it was not replaced, but mitral valve was repaired using an angioplasty ring, then he has to be given prophylaxis. So while advising prophylaxis, it has to be seen what procedure the child has underwent, whether it had a previous history. Then these dental procedures are very common because dental caries, root canal are very common. Dental extraction is very common. So any oral procedure which is being done, oral surgery or dental surgery, suppose biopsy has to be taken, then also we advise that one shot of antibiotic should be given. If at all, if the child undergoes root canal treatment or scaling, even scaling, they said that periapical lesion.
So, Dr. Adi, what you are saying is in rheumatic heart disease, we advise antibiotic for all cases. Here, only few cases out of congenital heart disease, there will be a need for prophylactic antibiotic.
Yeah, sir. Very few procedures, very high risk
Which
patients.
you mentioned. If there is a previous history of endocarditis already happened,
If previous history of antibiotic, yes, sir. Previous history of
or if there is a prosthetic valve which has been put, then they have to get. Otherwise, no. Okay, great. For
Sujata
Dr.
ma'am?
Khan,
सर एक सुजाता मैम के लिए भी क्वेश्चन है.
Yes.
सुजाता मैम,
Yes.
ma'am, what is the time when we need to give the obturator to the kid for cleft palate?
See, as far as immediately after birth is concerned, we don't